Well, good evening, everyone, and welcome to our webinar tonight, which is going to be a sexual health update. I'd like to start by acknowledging the traditional owners of the lands, all the lands in which we meet tonight, and pay our respects to their elders past, present, and emerging. But just before we get started, if we go to the next slide, please. Just to remind you, for those of you who've done this before, if you could please use your Q&A function at the bottom of your screen there in the middle, rather than the chat. So Q&A for questions that you want to give to the panelists. Use the chat function if you've got any tech problems, and one of the team will help you with that. A reminder as well that there is, at the end of the presentation, there's a QR code which will be shown. If you just use a device to scan that code, or to take the link off the chat, which we'll put up at the end, and then that will be for your CPD. So tonight we're delighted to welcome Ryan Williams and Fabiola Martin to take a look at giving us a bit of an update around sexual health. Thank you very much to those of you who have submitted questions, which Ryan and Fabiola will be dealing with during the course of the webinar. Don't forget, at any point, if you'd like to ask questions or clarifications, just pop that into the Q&A button and we will get to it through the course of the presentation. So without further ado, next slide, please. We're going to hand over to Ryan, and Ryan, at this point, you need to unmute so we can hear you. That's it.
Thank you very much, and good evening to everyone. Thank you very much for your time this evening, for the wonderful welcome, and I really look forward to being with you. It's great to be with GPs, those who've chosen the best career in medicine, and so to the registrars, congratulations on choosing a great career, and any medical students watching, consider general practice, great career, you will love it. And so yes, so that's a little bit about who I am. You can read my letters and all that kind of jazz, but I work in a predominantly LGBTQ friendly medical center. I do a lot of sexual health as well as general practice in there, and very happy to talk about sexual health tonight. So looking forward to that. Next slide, please. So general practitioners, general as we are, the GP in this slide, obviously, it's got the looming coronavirus in the corner that they've got to worry about, but you know, in the midst of a pandemic, has still got to worry about things like heart attacks and strokes and acid reflux, but patients are still having sex. And I think that the day that patients stop having sex is probably the day that we'll all go out of practice. It's part of life. It's part of the human experience, part of the patient experience, part of our experience. So we need to consider that and consider what do we need to be doing to help our patients through this time and what's affecting them. So next slide, please. Sex during a global pandemic. There's emerging evidence about what's happening about this, but I guess in this situation, I'm going to be speaking more from an anecdotal point of view and the discussions I've had with colleagues. My observations have been, in terms of what I'm seeing in my patients, has been more of a move towards patients showing an interest in risk reduction, in terms of isolating what risks are there and what risks can I reduce. And that can look at things like their own sexual behaviours. That doesn't mean, I no longer want to engage in oral sex because it's COVID. Not things like that, but they might say, well, I used to be somebody who might be interested in meeting people in bars, but now I don't really want to go to bars because you've got to be 1.5 meters and things like that. So maybe it's more convenient for me to use, you know, hookup apps or things like that, or I can negotiate safety on hookup apps about what's this, that, and the other. And so they can use different ways of negotiating safety, not just, you know, emotional, psychological safety, but also physical safety in some of the ways that they find their partners and things like that. So there's certainly been a bit of a shift in that, in terms of how people are guaranteeing their safety. People are reviewing their partners and their health, the health status of their partners. So people are checking in just to make sure that they are healthy or clean. People also often will come in to me to say, I just want to check that I'm clean, doc. So their words, not mine, but that's what they will say. They're also tending to start to more check out like, oh, I wanted to make sure that my partner had had a full sexual health checkup, which to me is very interesting because as a doctor for quite a number of years, I've heard patients saying, "Oh, he looked clean," or "She looked clean," and I'm sitting here thinking, "You can't see the bugs, sweetie. You can't. I could tell you the names of all the bugs that are on that person, but they looked clean." But now there's at least in some people that I've talked to, they've been more, I made sure they've had an STI test in the last little while, or so people are moving more to guaranteeing or looking at least at their partner's health status. I've also seen there's been a bit of a shift in terms of looking at prevention. And that's, something that's very interesting to us as general practitioners, ways that we can prevent STI transmissions that I guess are particularly interesting in the field that I practice in, whereas I have a lot of patients who are MSM or men who have sex with men. That means they either identify as gay or bisexual, or they don't necessarily use those labels, but they do have sex with men. And so HIV prevention is high on that list. And so one of the ways that we know is an excellent way with very, very good data to prevent HIV is the use of PrEP, or pre-exposure prophylaxis for HIV. Hopefully many of you have heard about this. It's a 2-drug fixed-dose single tablet medication. It's PBS authority streamlined. You don't even have to ring up for it. Hallelujah. None of that music. You just get it straight away. Just type in a 4-digit code, and it's for individuals at medium to high risk of HIV infection, defined by the ASHM, or Australian Society for HIV and Viral Hepatitis Medicine guidelines, and they have to be HIV negative from a recent HIV test. So I'm not going to try and teach you how to become a PrEP prescriber in 5 minutes, because that's not possible. What I do want to say to you is that I think that prescribing PrEP is something that is designed to be quite simple and quite achievable and doable for general practitioners. It's not something that only specialist sexual health physicians can do. Sure, there are some situations that we should be involving our specialist colleagues, but PrEP is not something that we should be thinking, oh, it's only for the sexual health consultants. It's actually run-of-the-mill GP work in 2020. And I've got some references at the end of this in case you need some help wanting to read more about that.
I'm interested to know, do you have any data offhand to know what the prescribing rate of PrEP amongst Australian general practitioners is at the minute? Or
that's a very good question. What do I know? I do know that it has increased. I do know that, what do I know? I'll have a think and see if I can get back to you on that. I do know that I won't hold up here, but I do know that it has increased significantly, and that initially PrEP was being accessed in nowhere near as easily accessible places like a regular GP. I still occasionally get phone calls, even me as a specialist general practitioner, I still get phone calls from family GPs who call me because they've got someone who wants to go on PrEP and they're a bit unsure about it, and I'll talk them through how to start that and give them some information about it. But by and large, it's becoming more and more taken up by general practitioners across the primary care field, and not just seen as something that you have to go to one of those medical centres to get access to.
Thank you.
I think it would be a really reasonable exam question for those of you preparing for either RACGP or ACRM exams.
What, managing a patient with PrEP, Rebecca? That would be...
Yeah, managing somebody who came in to ask for it. I think that would be perfectly reasonable.
Yeah, thank you. Thanks, Ryan.
Moving along, the last thing I would say, obviously, just in risk reduction, condoms do reduce risk reduction in terms of bodily secretion. So just to mention that in there, but I'll keep flying along. Next slide, thank you. All right, so a quest to test. People coming in and they want to check that they're healthy. They want to see their GP for an STI screen. So look, this is perfect chance for us for health promotion in general practice. Now, we've seen with COVID-19 that testing early and often is how we prevent the spread of infectious pathogens. So when it comes to STI testing, I think that one of the most useful questions to start with is about, do you have any symptoms that are worrying you? Because this really helps us to differentiate the patient who is asymptomatic screening as opposed to the one who's got symptoms and needs symptomatic testing, because they're quite different algorithms. And so that's why I think we should focus on that. I do also say that I think it's helpful to ask, is there any particular reason that you're here for an STI test today? Because the person might come in and they may not have any symptoms and they ask for an STI test, but they might say, oh, I did get a text message yesterday from someone I slept with last week and they've just tested positive for chlamydia or gonorrhea, or they might be worried that they slept with somebody and they've just found out that person's got HIV, or they might have had some sex on the weekend and it wasn't so consensual. I think it's important to give space for there might have actually been something else that's driving it. So I think apart from the dichotomy of symptoms, no symptoms, is there anything else, I think is also very important.
Just on that, Ryan, with saying sort of symptoms versus asymptoms, one of the audience questions did really ask about symptoms for screening for Mycoplasma. And I wondered if, would you like to cover that now or a bit later?
I'll cover that in the next slide, actually.
Okay,
that's okay.
Great.
Yeah.
And Ryan, I'm just going to hop in because there was a very interesting comment that's come up
Sure.
from someone saying just about PrEP, that they've also prescribed it in ED with support for sexual health, so as residents. So that's good to hear as well, isn't it? Yeah.
That's really good. That's fantastic. Great. Excellent. Okay, can we have the next slide then? So what I'm just going to say about, I would encourage everyone, GPs, registrars and medical students, when it comes to what to test and how to test and what to treat and all of that, I would encourage all of you to be using this resource here. This is an accredited clinical resource from the RACGP, which means that this is actually high yield in terms of something that is examinable for your exams, but also this is best practice in terms of sexual health for GPs, for sexual health physicians, for infectious diseases, end of. So this website here, I put it in the slides, you can use it. It's very, very helpful in that you can look at things by actual specific STIs. You can look at things by the actual STI syndrome, like if they've got urethritis, but I don't know what it is, or they've got a lump or an ulcer. And then you also here, talks about particular populations and situations. So who are particular at-risk populations, like Aboriginal and Torres Strait Islander people, or pregnant women, men have sex with men, sex workers, transgender people. So it's very, very user-friendly and it is best practice. So this is where all of what I'm going to talk about now comes from. It's not what I think, and you should believe me. All of what comes from now is directly from this resource. Next slide, please. So asymptomatic screening, what to test? Well, this is really what I think is what comes straight from there. Now, we're basically going to be trying to test the most common mucosal membranes and surfaces that are going to be involved in sex. So you test the throat, we're going to do a swab for chlamydia and gonorrhea, PCR, genitals, now that's basically your the urethral lining in male for the penis, and or thinking about vagina for females, and either whatever that variation is going to be for cisgender people. But we're looking at really just getting urine because that's going to be the most that will catch whatever we want. So we want urine for chlamydia and gonorrhea PCR. And then the anorectum, we want just an anorectal swab for chlamydia and gonorrhea PCR. So I'll stop there. Now, we used to spend quite a lot of time trying to work out, have you ever had any anal sex? Have you ever had any receptive oral? Like, we used to spend a lot of time asking lots and lots of questions to work out who gets what. Now there's a lot more focus on just saying, just offer everybody every test and allow patients to say, oh, I don't do that, I don't need that, that's not necessary for me, they're absolutely within their rights to decline. So that's fine. If a straight male says, I don't want no throats, I don't take no dicks in my mouth, then that's fine. And if they say the same thing, they don't want to have a rectal swab, that's their choice. But if we sell it to them as trying to say, this is what a complete sexual health screen looks like, and look, sex is messy, and secretions get everywhere, and I've treated immaculate infections a lot, which is very true. I've treated a lot of immaculate infections because we don't know who's actually doing what in their sex lives. If we offer this and allow patients to opt out, offering that suite of swabs everywhere and allowing patients to opt out, I think is the easiest approach. And yeah, we can talk about in the discussion later if anyone has any different ideas about that, but that's what I think is the simplest way. In terms of, in an asymptomatic individual, there is no role, and evidence and guidelines say there's no role in testing for Mycoplasma genitalium in the asymptomatic individual. So we'll talk a bit more about in the symptomatic individual, but asymptomatically, individuals without symptoms, no testing for mycoplasma, no role, wasted tests. Okay.
So, Ryan, this is very much the person who turns up asking for an STI check, and when you double check, they say, I'm going to start a new relationship. I just want to double check that everything's okay. They've got no symptoms. This is your, this is for you. Yeah. So no mycoplasma in this one.
Yes, very much so.
Yeah. Yep. Beck, I think there are a couple of questions there. Did you want to is there anything there to?
That was the main one. The other one is perhaps, it may be a question for Ryan, it may be for Fabiola a little bit later, but why do people sometimes have an STI and not present with symptoms?
I think Fabiola had an answer to that she might like to talk about
yeah.
a bit later.
We'll hold that one then.
But it is very relevant. I guess the most important thing that I would say, I don't know that it's probably something that we could talk about for quite a long time. I think that the key thing that is a really important thing about that question is that lots and lots and lots of people have asymptomatic sexually transmitted infections. They carry them in their throat, they carry them in their vagina, they carry them in their anorectum, and they don't know that they have them. And that's part of why I really, really advocate, and I think most sexual health doctors really advocate for a thorough and complete screen, because you do, and to be, without being judgmental or deriding of my colleagues, I have many patients who are at higher risk, or many gay or MSM patients who come to me, oh yes, I had a sexual health check at my family doctor a little while ago, and they've never had a throat swab or an anorectal swab, and they've never been screened appropriately. And that's dangerous, because I then do a swab and it turns out they've actually been carrying chlamydia in their rectum for goodness knows how long. So whoever asked that question, it's very valid. It is possible in men and in women. Unfortunately, women can carry, chlamydia in their genitourinary tract for years and years, and then scar up their fallopian tubes and not find out until they're infertile. So biology is cruel. The exact mechanisms, I'm not sure we have time to go into tonight. I think the most important thing, though, is that testing's the way to find out. That would be my short answer. If I could just talk about...
Sorry, Ryan, we're not going to be able to get off the slide for just a little bit longer.
So that's what I said. So blood, I would say HIV serology, syphilis serology, and Hep B serology. Hep B, if you know that they're immune, no point. But if you don't, do the Hep B. If you're taking blood, I would consider doing immunity to Hep A in at-risk individuals, and you can look on the website to see who is at risk for that. And Hep C serology once a year in at-risk individuals. Next slide.
No, just before, you can't get off this one.
Yeah, no. Yeah. So just okay. Like looking at the difference between high vaginal swab as opposed to urine collection. Can you speak to that at all?
Well, actually, this is where I'd like to talk to Fabiola, because I rang her yesterday to ask her this question, but she was far too busy seeing patients. So
Fabiola, come on in and tell us.
Hello.
What's
Okay,
what is
so
the latest evidence in terms of?
So it's not just evidence, it's about practicalities and who will you accommodate and who will slip through your net. So we want to test everybody as much as possible when indicated. So when I started my training, I was testing every woman, and I was taking cervical samples. And that may have deterred women to come in. Then we moved on to high vaginal swabs, and that is still the gold standard. The gold standard is cervical screening. Next is high vaginal. If you really have a woman who can't take their own high vaginal swab, then offer a urine. This is how I do it. Because at the end of the day, I want my samples to be collected as closely to where the site of infection is. Chlamydia likes the cervix intracellularly. So what I say is to my women, take this swab, put it all the way in and twist it 20 times because I need you to collect cells. In the cell is the chlamydia. So in, out doesn't work.
Yeah.
So high vaginal swab, cells taken high vaginal swab, and then next, if they really, really hate it. So for example, transgender patients may hate it because they have dysphoria, then I offer a urine.
Yeah. Do you offer routine chlamydia gonorrhea screening on a thin prep when we're doing CST?
Is that me?
Yeah.
Not routinely. It depends on the history of the patient. If I have already tested them, then I won't. If they, we discuss risk at length. So I have more time than GP, so I discuss risk at length. But I don't add it on routinely, no.
Yep. Ryan, can you tell us about the throat swab and where exactly you take the throat swab?
Sure. So people are getting a bit more familiar with the throat swab now in COVID times, but so with the throat swab, we really want you to actually get the posterior pharyngeal wall, and we also want to get the tonsillar pillars. So you actually do, I try to make it a bit of a joke with my patients when I do them, because it does actually make them gag a little bit and cough a little bit. And I sort of make a bit of a joke with my patients that I say, they teach us at medical school, if you don't cough or gag a little bit, I didn't do it right. That's the way that I sort of tell my patients, because they all kind of gag a bit and cough and go a little bit like, what's that all about? So I hope that's helpful. Are we still stuck on this slide?
I think we are.
Okay, so shall I talk a bit about mycoplasma just for a second?
5 or 6 questions on this, Ryan. So
okay. Oh, that's fine.
So just, can we stick with the tonsil swab?
No, fine.
There's a comment here about a feeling that as practitioners, we're far more familiar with seeing positive throat swabs in men than women. Mm-hmm. Is that because we're under testing women, or because actually there's a true higher incidence of positive throat swabs in men?
I guess, so this would be also something that I'd be keen to hear what Fabiola says about, but it also depends on what the swabs are actually positive for. And that's because we talk about the organism, is it chlamydia or gonorrhea? So chlamydia is the most common STI in Australia, purely numbers wise, but gonorrhea is more common to be tested positively in the throat. And as that's got part to do with what Fabiola was saying about it being, it's an extracellular organism as opposed to an intracellular obligate organism. And Neisseria gonorrhea is much more common in MSM communities, and it is spread through, obviously, oral intercourse. And so it is easier to culture and to collect the DNA, which is what we are testing for. If you're doing a throat swab for gonorrhea, it's harder to collect the DNA from chlamydia trachomatis, which is what you're going to get from heterosexual transmission, which is what we're thinking about in the majority of females who are going to be collecting. If you're thinking about simply just speaking about sexual anatomy now, if you have a heterosexual female who's going to get a chlamydia infected penis rubbing against the back of her posterior pharynx, that's you're then going to have a more difficult time getting the obligate intracellular chlamydia trachomatis DNA out 3, 4, 5 weeks later. It's less likely, whereas gonorrhea, different story, a bit more robust, more likely to say they're still not going to cause symptoms. It doesn't cause a particularly nasty pharyngitis that, oh, my throat's terrible, I've got gonorrhea again. It doesn't cause that, but more likely to be robust and to be collected on throat swab. Would you agree with that, Fabiola?
Fabiola, anything to add to that?
I think I'll just make it very simple. Chlamydia and gonorrhea, STIs, are more common in people who have a lot of sex. So MSM typically have more sex than the rest of the population. Of course, this is a generalization. Some women have more, etc. That's where chlamydia and gonorrhea is more commonly seen in the throat of the men. Also, MSM population is more often screened than the heterosexual population. So a very active MSM should have an STI screen every 3 months. Women are, as someone I read the question as well, correctly say, less likely to be offered all 3 tests. Okay, we assume they have only vaginal sex. We assume that the partners don't have chlamydia. So I'm supporting offering all 3 tests to all people who are sexually active. And the positive rates will be lower in heterosexual people compared to LBGTIQ population.
Thank you. That's a very comprehensive answer. And just quickly, the last one is, and I obviously, you know, up here in the north, well, where I work and across our demographic, we have very high incidence of trichomonas. Can we just get your view on the testing for trichomonas in an asymptomatic patient? So not the patient who's come in with symptoms, or the patient who's come in for a screen, or they've turned up for a CST. What would be the advice on that?
I would have said, in the absence of discharge, in the absence of vaginal symptoms, pruritus, itch, malodor, I wouldn't have said that that's something to be screened for. It's in my slides to talk about as soon as somebody is symptomatic, I would put that down there. That's my simple answer. Fabiola?
I have yet to see a patient, a woman and a man, without a discharge and trichomonas. I have yet to see trichomonas in a man because they wash it out. But in women, I have never seen trichomonas without discharge.
Thank you. I think, Ryan, we might be able to let you get off the slide.
Well, I just hope it was a helpful slide. Anyway, that's good.
Very, very helpful.
Okay. All right. So then this one will probably be also interesting and or have some questions. So if someone comes in and they're symptomatic, I would encourage you, make sure that you do all of the same tests. You don't do, oh, so I'm not going to do any of it. You do the same tests that we've just talked about, and then you add on top of that. Now, if a male has got urethral discharge, and I'm not being sexist and putting men top there, but because one of the most frequent things that you will see, and because it's simply unfortunate that biology is sexist, and if I've got an STI and penis, it's symptomatic. So male urethral discharge, please do a swab for MCS, not just to try and work out what the organism is, because you probably will get that from the urine, but to get an antibiogram. We want an antibiogram to know what it's sensitive to in regards to treatment. Vaginal discharge. So this is where we do want a high vaginal swab for MCS, and that's where we're looking for a number of different things. We want to see, is there yeast, are there clue cells, is there signs of bacterial vaginosis? If there is vaginal discharge, on the PCR, you can actually add, and looking for trichomonas PCR. So you can already add that on and say, look, can we get, I've already asked for a PCR for this and the other, can I add on trichomonas for that? If you've got the urine, so I would be adding on the trichomonas to the request that says chlamydia and gonorrhea that you've already got preloaded in your software. I'd say add on the trich. Obviously, for vaginal discharge in a female, trans, cis, doesn't matter. If there are red flags like suggestions of cervicitis, bleeding, infection, anything that makes you think that that there could be PID or anything nasty, you really are, that's a situation where you absolutely do need to do a pelvic exam and think about pelvic motion tenderness and do they need to go to ED.
Ryan, could we just take a slight detour on the vaginal discharge question, because one of our very experienced supervisors who actually works in the demographic I was talking about with a lot of trichomonas is asking a very specific question. The ASHM guidelines say don't treat trichomonas in pregnancy before 20 weeks, but we hear from our obs and gynae colleagues to say yes to treat if there are symptoms. What would your and Fabiola's advice be on that, please?
This is a Fabiola question.
And Fabiola's actually answered it in the chat.
I can explain it as well. So I follow also the British Association for Sexual Health and HIV. So metronidazole is safe in pregnancy. However, who is pregnant in the first trimester likes to take metronidazole. It has very nasty side effects. Women throw up badly, and really the medication doesn't get to where it should go. So if the woman is terribly symptomatic with vaginal discharge, treat it by all means whenever the woman tolerates it. However, there are some clinicians who use it later on during pregnancy because the woman is more likely to have, overcome their early pregnancy nausea. Is that helpful?
Thank you. Yes, I could see Jackie nodding. I'm sure she's nodding. Yeah. Ryan, back to you.
Anogenital ulcers. So one of the things you would be thinking, hopefully, in your differentials would be herpes simplex and genital herpes. So you'd be doing a swab to collect for HSV PCR, but always think about syphilis, because syphilis can present with ulcers. So syphilis PCR. Do a chlamydia PCR because lymphogranuloma venereum can present like that, and do a swab for microscopy culture and sensitivity in case it's just an odd bacterial cause that we're not completely sure about. So that's my approach to ulcers and general kind of rash around the genitals, is to do, that's kind of my awesome foursome that I always do. And if it's not those four, then I kind of think then it's probably not sexual health, and it's probably could be dermatological, and that in a different wheelhouse then.
Excuse me, Ryan, are these just for those of us who don't do this all the time? These are 4 different swabs.
It actually depends on which particular pathology company you're going with, because some of them will have some of them will want a different one for syphilis and HSV. Some of them will want the same one. MCS is so MCS and PCR always going to be different. So you have at least 2, probably 3. It just depends. I always check with the pathology company. I've got the A4 sheet of collection swabs next to my path that I pick up. So that's just a check with, if you're using whoever you use, just check with them what their guidelines.
Make sure you've got the right ones. Thank you.
Very good, but it's very practical because there's no point if you don't collect it on the right one, the test is useless. Proctitis, if people come in with anorectal stinging, burning pain, that kind of stuff. I mean, if it's going to be in the sexual health wheelhouse, not GIT disease, you're thinking about swabs for herpes, thinking about MCS, and then also they should have had an anorectal swab chasing for those lymphogranuloma venereum serovars. So LGV is serovars L1, 2, and 3 of chlamydia. So it's just one particular subtype and can cause a really nasty proctitis. I've seen it and it's pretty awful. So just making sure that if the chlamydia does come back positive, that you make sure that they do have sub-tested for the serovars of LGV. And then lastly, epididymal orchitis. Most of you would have seen that, at least heard of it. You don't actually need to add on anything for that. Just testing for gonorrhea and chlamydia in the urine is sufficient. So I'll leave that there, and I'm sure there might be some questions.
Yes, we might want to address the Mycoplasma one now, if that's okay.
Okay.
Yeah,
so,
I thought so. The specific question about this is that why is there's such high resistance to, like, antibiotic resistance to Mycoplasma, despite it being, not as prevalent as some of the other STIs, although you might argue its prevalence at the moment because it seems to have risen.
Question.
That is an excellent question. I mean, look,
We've got a very bright audience here, let me tell you.
Absolutely.
On your toes here.
Look, there are epidemiological factors that drive natural selection and resistance issues. I think there's also been a lot of an issue about amongst us as the medical profession about how do we adopt a unified approach to how we're going to treat this, because I think for quite a while there was not. I still don't. I think that we in terms of the people. I'm on the committee of people who review the national guidelines. And so I know that the people on the national committee, we all know what the guidelines say about how to treat mycoplasma, but I'm not sure that if we asked every GP, or if we asked 100 GPs, you know, in hotspots around Australia, and said, what are the guidelines about mycoplasma? I'm not sure that they'd all know what it was and then all follow it through. I think there's been a bit of disparity about that. And so because of that, I think there's been some of them who would say, well, we're pretty sure we treat it with azithromycin, that's what we do. And so then because there is that, you know, significant percentage that escape treatment, well, or have failure of treatment with azithromycin, then there is, you know, that then puts pressure on, and even more and more who then fail therapy with that, and then need to be treated with the quinolone. So there is a combination of, you know, just genetic pressure within the population. Then there's the issue that we haven't done quite as good a job, I think, just as colleagues and doctors throughout Australia, having a uniform, this is how everybody knows to treat it. And that's not blaming anyone in particular. It's just, I just don't think we've done a good job of getting the message out.
It's interesting, isn't it? Because we use ETG. Sorry, Fabiola, go ahead.
May I just comment on that? So I like the question very much, and the answer is very simple. We have not investigated MGen for the antibiotic that would work for it. I just take things off the shelf because I have nothing to treat MGen with. The antibiotic resistance that we have is against macrolides and quinolones. They weren't developed for MGen. And this should take you further into why is no one investing in this? Because as you know, if you look at the antibiotics, at the arsenal that I have to treat sexually transmitted infections, bar HIV, everything else is about 200 years old. I'm exaggerating, but seriously, no one invests in the GU STI patient. Because how many STI patients do you know who go on the street and complain about not having had the MGen treated because it's such an embarrassing issue to talk about? So this is a very good question, because pharmaceutical companies are not interested in developing specific drugs for specific STIs. This is one of the reasons why we have so much resistance for the treatment of gonorrhea. And what do? We just take other drugs, combine it. There is no real evidence that it'll work, but that's all we can do because ciprofloxacin is gone. Now, by the way, ciprofloxacin is coming back because the last 6 years we were told, 10 years we were told not to use it. So this is how we are using and reusing, but really nothing has been developed for MGen because it's the new kid on the block. And you know, no one's really interested. The patients are not rich. They're not, you know, huge numbers. So that's where we are. We're stuck.
That's so interesting. And I wonder, could we stay with MGen just now? And Ryan, we note, both Rebecca and I, we both went to ask the question because we noted you haven't put Mycoplasma genitalium here on your swab for vagina. Is that because you don't recommend that we do that for symptomatic patients, or you do?
It was more that I was going to talk about it in the sense of, I think it's something that I definitely think that it is something that should be considered, but I don't think it's something that should be done for all patients. But I think that it depends a lot on local epidemiology and where you are actually working, because I think if you're working in areas where there's low rates of it and the patient is, you know, if you know the patient, a lot of general practice comes about knowing our patients. And if you think this is not a patient who is at very low risk of that, it's probably not going to be that. That's probably not what you're going to do. Whereas if you think, no, this patient's got symptoms and discharge that really could be that, I think I'll include that. It's very, very reasonable. So I think we're now in a time when somebody with symptoms, male coming in, urethral discharge, could be gono, could have MGen, could have all three. I mean, I have had patients who've got the trifecta before. That's possible. So, but if it's somebody who it's their first STI and it looks like it's chlamydia, you might not want to jump the gun and just go, well, because I guess part of what I think, and in talking with Fabiola beforehand about this, is that I think a really important take-home message, if we're talking about Mycoplasma, would be anybody who is ordering a test for Mycoplasma, you've got to provide a number and you're ordering a test for Mycoplasma, then you need to, just like ordering a D-dimer, you need to know what you're going to do if the result comes back positive. That's probably a more important thing to take home from this, not about just when do I do it? If you are going to order that test, what are you going to do about it? Now, the guidelines that are available from the Australian STI guidelines are helpful in pointing you in the direction about basically you put the patient on doxycycline as basically because it's bacteriostatic, and it will keep the patient at bay until you can work out what to do in terms of organizing some testing that it explains a bit about whether the patient is resistant to macrolides or quinolones or what's available, because sometimes they're resistant to that, or they may not, in worst case scenario, they may even be allergic to quinolones and they can't do that. And then you need to ring someone like Fabiola and say, what do I do and how do I negotiate that? So you need to be aware of what to do if the patient comes up with a positive test. So that's probably what I would say about that.
Thank you. I'm suddenly aware it's 20 to 8.
Yes.
We've got so many questions flooding in, but we might get you through your slides, Ryan.
Yes. So I can actually jump through quite a few now in the sense that if we can go to the next slide, please. What I'm just going to say, and we can actually literally, I can finish in about 2 minutes now, is basically just to say, in terms of treatment now, all the last couple of slides are literally just copied and pasted from the Australian Sexual Health Guidelines. So you can read through these. They talk about what the management is. So this is absolutely AKT. You should just know what these things are. Please note that there are, it used to be just one thing for, one treatment for all sites and all things. That's no longer the case. There are different treatments for different sites and different situations and different tests of cures. So please note that. But as long as you note that, you can do that. So that's the answers, well, the information at best practice. Yeah, it's for chlamydia. Next, please. Same information for next. Thank you. And for gonorrhea, it's all there for you. Next slide. Thank you. Syphilis, same thing there. Talks about different types of syphilis. Just a bit of information there about syphilis, but you can read it. It's all self-explanatory. Next slide, please. And then it also talks a bit about genital herpes and what's going on there. But that's me. What I've got here, there's an article, a link to an article from the NPS about what is PrEP, how it works, what it's all about. If you read that, and then you have the 2-page decision-making tool from ASHM, you will have everything you need to be able to prescribe PrEP.
Thank you so much.
That's the 87-page guideline there, but you don't.
Can I keep you there? And Fabiola, just ask you as well. There are just a couple of questions that we just quickly want you to talk to briefly. What's the current epidemiology on LGV in Australia? Is it from travel? Do we know? Do we have any epidemiology on that, please?
Fabiola or Ryan?
Either.
Ryan?
I don't know numbers, but I've seen infections that are not travel based. I've seen the patients that I've seen who've had it have been from chemsex.
And the other one, just to ask, you talked about hotspots. Do we have a way, apart from local anecdotal medicine, local anecdotal stuff, of knowing where there's a hotspot? So we always joke in Townsville that we're the chlamydia capital of Australia, but to be honest, I haven't checked that data for a very long time. Where would we find that out?
Hotspots for different infections?
Exactly right, yes.
Kirby Institute.
Kirby, Kirby.
KIRBY. Yeah, they also release every year a summary of all STI prevalences.
The other good question that I saw come through is, when do we test for cure? Or do we ever test for cure?
Those answers are on my slides.
Okay, great.
Fabiola, over to you.
Hey, thank you so much. Thank you, Ryan. That was fantastic. Aren't you amazing?
Not as much as the lady you're about to hear from.
Oh, I love that. It can go back and forth for a long, long time. We can do that really well, Ryan and I. So I'm Iranian, and as you can see, I'm a consultant physician in sexual health, senior research fellow at School of Public Health in UQ, where I do my HTLV research, and a clinical educator at True Relationships. And if we go to the next slide, please. I was born in Iran, did medicine in Vienna, and then did all my postgrad training at St. Mary's Hospital, where I did a MD, PhD in human T leukemia virus. I can't wait to be invited back to talk about that very important sexual health bloodborne virus, Rebecca. And then I was senior lecturer and consultant in York. And then next slide, please. I moved to beautiful Brisbane in the beautiful sunny Queensland. So I practiced at 4 different clinics. Lillian Cooper, we are just waiting for the provider number to come through. Next slide, please. So what do I do? Sometimes I ask myself what I don't do, and what I can't do is really be you guys. I can't do GP work as much as you can do. You can sort out all sorts of people. I can just sort out a very narrow group of people, usually with lots of kind of complex problems. Obviously, I'm an S100 prescriber. I look after sexual health, well-being and aging, function, dysfunction, contraception, mostly complexities, but also a lot of training and education, because patients love to go through the details of what contraception would be best for them, typical use and practical use. Menopause and complexities, transgender health, youth sexual health, sex worker health, pregnancy and complexities when it comes to the STI part of it, and then HCLB medicine. Next slide, please. And I thought it would be maybe helpful for us to review a little bit what I usually do. I just realized, it took me a while to realize how few STI, so sexual health physicians, there are in Queensland, 9, and only 3 in the community, all 3 in the south of Queensland, and only 1 female STI sexual health specialist in the community. So let's say in April, I took the date out, just thinking a bit paranoid, but I know the date. I saw these 4 patients back to back. An 18-year-old transgender male who came to initially just review their STI and endocrine results, but then said that they're very distressed by the period. So we had medroxyprogesterone prescribed. And then also, while we were talking about that, revealed that they probably have been abused as a child sexually by a family member. And so we managed to agree for a referral to a psychologist. Next was a 24-year-old man who has sex with men. We reviewed their gonorrhea results, which was a test of cure. So that was a good question. Yes, for rectal gonorrhea, pharyngeal gonorrhea, I need a test of cure because the antibiotics that we have, which is old-fashioned, et cetera, don't really necessarily get to where they need to go. And then physically, they said that they have a new onset of generous rash, mostly bothered by genital rash. And when I examined them, the body rash was there, the genital rash was looking better, and that was because they were already using some topical steroids. They had psoriasis guttata. 36-year-old female telehealth from Hobart. This is a lady who went to donate blood in December and was told that she can't because she has human T leukemia virus type 1. She then could not find anybody to see her, give her advice, plummeted into major depression. And then I saw her, discussed with her symptoms. She's an asymptomatic carrier. And when we planned the assessment management and contact notification. 30-year-old female, non-binary. She's a sex worker, has been in this line of work for many years, very successful, and actually is also kind of creative dancer and has thousands of followers. Has had major depression in the past, came for a routine screen, needed also CST and a certificate, and she revealed that she has no problems to work, but she has problems to have when having sex with her regular partner. So I did a female sexual function index assessment. We differentiated between the different types of sexual function / dysfunction, and she was diagnosed with a situational HSDD, which is hypoactive sexual distress disorder. And so she was referred to a sex therapist. Next slide, please.
So Fabiola, I'm feeling heartily thankful that I don't do your clinic at this moment. I don't know that I would offer anything of great benefit to. There were a couple of things there. So let's hear about why the sexual health specialist.
Today, for example, was a back-to-back clinic from 7:30 till 5. It was fantastic. Every patient was so different. So while I agree with Ryan about GP being a fantastic, line of practice, I think sexual health is even more exciting. The stories I hear are fantastic. The distress that you can relieve is a very rewarding thing we do. But I want to say that I think GPs in Australia may not have been seeing enough of us to know how they can utilize us. So more and more GPs, especially at Stonewall Medical Center and our GP Spring Hill, realize what they can use me for. And the way they think about it is, I can book 45 minutes, 30 minutes. All of my patients' first appointment is 60 minutes or 45 minutes. All follow-up is 30 minutes. And I need that time. I need that time. Patients need that time. And we talk about many, many different aspects, and patients eventually come out with it because they have the space and they don't have to run away. So a lot of GPs see us as part of the team. They say, I do everything else. You deal with the sexual health. I do everything else. There's complications. Can you look at the contraceptive health? I do everything else. Menopause is very difficult in this patient. Can you look after that? So this is how we have been supporting each other in many settings. So see us as your support, as your team. I also have further access to allied health, sex therapists, pelvic physiotherapists. So I work with teams, chronic pain management teams. So this is why we work well together. I find my life really exciting. So
Fabiola, you mentioned that you were one of the few sexual health physicians that are available in Queensland, and we've got such a huge state and so much is rural and remote. What are your suggestions for those of us who are more rural and
So today I had absolutely, Rebecca. Today I had a young woman, a transgender woman, driving 4.5 hours to see me from Hervey Bay. Yeah. And so while I'm in Sippy Downs, they could have come, but still it's a long track from Mount Isa or I don't know, wherever. And I think, so watch this space, guys. I'm setting up together with my colleagues at Stonewall Medical Center, a statewide telehealth post-COVID, with video and with phone, and we are sending out invitations to GPs to utilize our services, to book remotely, and we will work with the local GP. If there is an examination required, we will book that. This patient that I saw today, I said, you don't need to come back in until you are here, or I need some tests, but even then I will liaise with your GP. We'll do it all in Hervey Bay. You don't have to come in. So yes, I'm very, very excited. I think we are very close. It's all done. GP letter, patient information sheet, flowchart, all is ready. All we need is the website and then the invitations going out to GPs. So
I think that's going to be a fantastic service. As you know, Fabiola, up here in the north, we've got excellent sexual health physicians within the public system, and they do a fantastic job across the geography. What we don't have is access into a private system or a system that, and so yes, we'll be very excited to hear about that.
I think there's just a lot of work to do. We also have fantastic physicians here in Brisbane, North and South and Gold Coast. And what we do is a mixed billing. So patients who have healthcare cards, pension cards, student ID, they're bulk billed. So we really try to accommodate as many people as possible.
Fantastic. Fabiola, very sadly, we've only got 5 minutes to go.
Fantastic, isn't it? All our questions
are.
Next slide if you want to. Next slide if you want to. So refer, as I said, complex cases, difficult to interpret results. Hep B results can be complex. Hep C results can be complex. So can be HIV resistance results. HTLV results go without saying. A lot of people just don't have the training or experience. Syphilis can be complex, especially if the RPR post-treatment doesn't behave as you want it to. MGen results, I would highly recommend to hook up, because we're collecting data statewide to have a better database, and gonorrhea resistance is prevalent. Reinfections, resistance, and age and comorbidities, this is the things that I think you could refer. Next slide, please. So one thing that I thought I dig in a little bit deeper for 30 seconds is that I see a lot of function dysfunction. So under the DSM-5, this is the Diagnostic and Statistical Manual of Mental Disorders, 5th edition. You can see under female and male sexual arousal and interest disorder. Today I spent an hour with a 32-year-old woman who had this problem. She had no sexual orgasmic disorder. She had no genitopelvic pain and penetrative disorder. Her husband didn't have erectile disorder or premature ejaculations, and so on. So I pulled it all together in male, on the DSM, you see male and female separate. But as you can see, I get a lot of women now sent to me at all different ages who have issues with wanting sex or enjoying sex, and we can treat that. And so that's that slide. And next slide, please.
Sorry, just before you move to transgender, Fabiola, there's a couple of quick questions if we could get through. Who should we be testing for HTLV, and if so, when?
I love this question.
I knew you would.
Okay, so this is my favorite GP. You will pass your exam. And I guarantee you there will be no HTLV question on your exam. Okay, HTLV is currently tested in all first-time blood donors. Last year, they scrapped the testing of second-time blood donors if they didn't have HTLV, because apparently they stopped having sex. Okay, that was a joke. A lot of people who have HTLV don't know, because unlike, so this brings me back to the first question, okay, if I may. Do you remember the question, why do some people have symptomatic STI, some don't? Rebecca, can I link in here? HIV infection, 98% chance that you will die in 10 years untreated. HTLV infection, 5% lifetime chance that you may develop a disease associated with HTLV. So these viruses evolved at very different times. HTLV thousands of years ago, HTLV only 150 years ago. Therefore, the immune system is much less adapted to HIV. HIV destroys its host and itself. HTLV persists with its host. Therefore, people who have HTLV are less likely to have symptoms. So you can't really look for symptoms too much. It is in, I'm just publishing a paper for Queensland. It is here, very low rates, similar to other low rate countries. Who should you test for? You could, people who have certain symptoms, and I will send you a reference for that. And people who have positive partners, and people who come maybe from endemic countries. Again, I can send you a list and you can screen for them because you think they may have it. Is that okay? Because of the time constraints. Because believe me, I can talk about this forever.
Yeah, thank you. Because Fabiola, we are aware, we think that many children in the territory have got it. That's the emerging data. So I think now, unbelievably, we are just about out of time. So what I was going to do is to thank you before thanking you and talking about next week and putting up the the QR code. Ask Ryan and Fabiola if you'd like to each say a last, just 1 or 2 sentences in summary, please. Fabiola, let's start.
Ryan, you first.
Ryan, you're on mute. Ryan, you're on mute.
I yield my time to Fabiola. I got plenty of time tonight, so.
Okay.
Oh, that's very kind. Okay. Just practice in front of the mirror how you ask the first question about sexual health. Practice that. So what I do with my med students is this. May I ask you about your sexual life? And then the next question is, would you like a baguette? And it should sound the same. Would you like a cup of tea? Can I talk to you about your sexual health? And the other thing that always works is I talk to all my patients about their sexual well-being. Is it okay if we talk about it? So if you just make sure that no one feels cornered, it's not that I think and look at you and think you need this, but I do it with all, and I offer all these tests to all my patients. Is it okay? Is there something you want to opt out? So you give a choice, but you have listed the tests and you haven't made that choice for them. That's it.
Can I ask you, Fabiola, just one last question here, briefly. How do you decide which patients require treatment for low sex drive and who simply needs help coming to terms with their asexuality? And you've only got 30 seconds for this, Fabiola.
The cue is distress. Are you distressed or are you actually comfortable? And often the patients are sent in by their partners. And so then you need to unpick what is going on in that relationship. That's called situational.
Thank you so much. Thank you, Fabiola. Next slide, just to let everyone know, next week we're looking at antenatal screening. We're looking at all the change in genetics and some of the ethics about that. Thank you so much to Ryan and Fabiola. Thank you, Beck. And we look forward to seeing you all next week. Good night.
Thank you and good night.